We're going to take a moment to talk about working on the anterior aspect of the thoracic region, or the anterior chest wall. The reason we want to do this is just to provide further explanation and further demonstration of some of the concepts we talk about. Now, in the case of the thoracic wall, the primary reason that you would be taught that you'd want to work here is for respiratory issues. Now, people will talk about disease processes, and I would say that I wouldn't put too much stock in treating for disease processes. So say somebody with COPD. COPD isn't necessarily an issue with a thoracic cage, it's an issue with restricted bronchioles. So it's a kind of an internal issue to the lungs that manual therapy is unlikely to do a lot with. Now, the basic hypothesis with respect to working on the thoracic cage in order to do anything for respiration is that if rib excursion is causing a mechanical problem, then we can do something about rib excursion. When working on the cage, the concept of direct and indirect really only starts to apply or seems clinically relevant when we're talking about a tender area. The big challenge that we have is that for ribs to work appropriately, you have to have kind of expansion and contraction, so you've got to have a full cycle of all the muscles to create the pressure differential, to create the size differential in the cage itself, to then create the opportunity for respiration. So when I say that the direct and indirect concept don't apply as much to treating ribs, or at least treating the anterior surface of the cage, it's because what we're really trying to do here is get good contact on the front of the cage to basically move the whole thing. The reason we want to do that, again, is hypothetically what we're trying to do is increase general excursion of the rib cage or of the thorax so that respiration works better. Let's just say you hypothetically, again, have an issue with partial pressure, you have an issue with creating the appropriate partial pressure or pressure differential through the lung mechanism to appropriately load oxygen or unload other gases. Then hypothetically, again, you may be wanting to do this. Now, when working on the front of the cage, again, remembering that I've said that direct and indirect don't seem to be as much of an issue here, much more so we want to consider full excursion of the cage, and we're working with a pressure mechanism. Because we're working with a pressure mechanism, what our behavior is going to show that. So usually what you'll see, or what you'll be trying to do, is to kind of hand over hand onto the sternum, right? So you can use this and lean on pressure, nice straight arms. So the idea when you're using straight arms is don't allow the position of your hands to move in relation to your body, right? So my hands are here, I'm not going to allow my hands to do this, right? So I'm not going to move my body in relation to my hands, I'm just going to lean. And the idea here is as the person breathes, you can drop a little farther as they breathe out, so you can increase the pressure and not allow it to change, because you're not allowing the sternum to move. And what you can do from here is you wait, and you use your eyes, and as they breathe in, you'll see the abdomen change. You won't feel a ton because of the amount of pressure that you're putting on, but you'll watch for the abdomen to change, right? And as the patient starts to breathe in, I can jump off, right? That creates a rapid change in the size of the cage, which creates a rapid change in pressure, which can create turbulence through the airway. The idea of creating turbulence through the airway is, let's just say there's something mildly obstructing it, like mucus. You may be able to disturb that mucus, dislodge it from the wall of the airway, and it may travel better, it may be dealt with by the body better. Now, whether that's true or not is up for discussion, but you will hear turbulence, you'll hear certain sounds when you do this. So again, you're just kind of leaning on, and as the patient breathes out, you sink in, and as the patient breathes in, you don't let them up, and then you watch, and as they start to breathe in, normally you can jump off, and that will expand the cage more rapidly than it will expand on its own. You can come wider in certain circumstances, depending on the situation, right? People will talk about this more being aimed at the upper ribs. It doesn't create as much of a pressure change because the sternum is connected to the vast majority of the ribs, so you have a better handle. But if you're more lateral and on the upper 3 ribs, upper 4 ribs, you can do this as well. Right? It changes the nature of it depending on the situation. As I showed in the video where I showed what treating the Spanish flu might look like. I showed this. Cross your arms on your chest. This allows us, when we do this, it allows us to stay away from sensitive areas on the anterior portion of the thorax. Man or woman, having your hands on the front of somebody's thorax can be a sensitive area, but here, this relies very much on vision because you're watching the person's abdomen. So you're still leaning in and kind of squishing the thorax, and it's really the arm that's underneath that's on their thorax that you're creating the pressure on. And you can still kind of do your jump or your jump off. I would say don't bring your hands all the way off, just kind of let off your pressure, and that allows you to do it. There is the opportunity under certain circumstances, if you're really trying to rapidly change the pressure in the thorax because you have some reason to believe that it's going to allow you to create enough turbulence to knock loose some mucus. It's basically short excursion pumping, such as you may see in CPR. And what you'll hear is you'll hear the from the patient, kind of like little huffs. It's uncomfortable, so you have to warn somebody before you do it, but you can do it under certain circumstances. Would I say that it's going to cure a cold? Would I say that it's going to fix respiration? No, I wouldn't necessarily say those things, but I would say that if you can identify issues with excursion of the thoracic region, generally speaking, you can use a method like this to help that. If there are problems that are associated with a lack of excursion, you may be able to help them. Such problems might be, clearing mucus, things like that, or again, the hypothetical reality of not having enough cage expansion to create appropriate partial pressures for loading and unloading of gases in the lung. Right? Again, that's more of a hypothesis. You could test stuff like that. You wouldn't need extraordinarily out of reach equipment, but the big deal is that if I suggest to you that this is how I do something for the heart or the pericardiophrenac ligament, or if I suggest to you that this is how I do something for COPD, I would be overreaching. But I can tell you that there is a way to work on the anterior portion of the thoracic cage that can definitely change pressure gradients by the speed at which you apply and allow pressure off, right? Or apply pressure and let it off. You can definitely change that. And then that can have certain effects. Are we 100% clear on those effects? No. But I can tell you how to do it. The reason, again, that I say that the idea of the barrier concept isn't as useful here is because what we're trying to do is change the size of the cage. We're not necessarily trying to work on the barrier. We're trying to change the size of the cage, use that pressure change to send whatever neurological information to whatever muscle, to whatever sensory nerve, but we're doing it on a large scale.